Hello again, everyone. Here today, we're going to be continuing on with our discussion of medications related to orthopedics. We finished off last time talking about some of our opioid medications, and so we're going to continue on along that vein for a little bit here. The first medication we'll talk about today is going to be Meperidine. The brand name is Demerol, although you'll hear a lot of people call it Demonol because it has some pretty nasty side effects associated with it. Now, this drug is almost never to be used, especially in the case of treating it or using it for pain management. Essentially, there's some problems with it, including, especially when you have older patients who have poor renal function. The drug gets metabolized down to a metabolite called normeperidine, and so normally this is renally cleared, but for patients who maybe not able to clear this as effectively, you'll see that it can lead to things like excitation, and then in severe cases, seizures can develop, and they can also have some other issues with things like dysphoria, tremors, and myoclonus. There's also a number of drug interactions seen with its use due to the fact that it has some mild monoamine oxidase inhibition. So similar to some of our older kind of first generation antidepressants, we know there's issues with tyramine reactions, so like aged cheeses and meats and things, and chocolate and red wine and all that. But not only that, but it'll also interact with things like stimulant medications like amphetamines you would see being used for ADHD. Not only that, but patients will end up developing tolerance to the medication pretty quickly, so that the analgesic effects don't really stick around for a while. So again, really avoided, especially in the elderly, especially those with renal impairment. But the one place you will see it being utilized most frequently is likely for rigors, and so you see this a lot for in the post-operative setting, in order to help prevent like shivering and things like that. You'll also see it sometimes being utilized after cardiac arrest when they're doing therapeutic hypothermia, in order to help prevent shivering, which again generates heat, kind of impeding your cooling process. You can utilize meperidine to kind of help blunt that. So again, special uses for this drug, but in general to be avoided. Next, you have Propoxyphene. Now, this one has been removed from the market, but then you never know what's going to be hiding in grandma's medicine cabinet. So it's certainly possible that you'll see patients who still have some of this hanging around. This is another drug that is also metabolized over to norpropoxyphene, which again is renally cleared. So you'll see that with patients who have poor renal function, CNS excitation is certainly possible, and seizure risk is going to be big here. Also, it's interesting, the popular combination drug, including propoxyphene, was Darvocet, so it'd be propoxyphene plus acetaminophen, and we see that in certain studies they actually show that there's no benefit to giving propoxyphene than just giving acetaminophen alone. So the efficacy was pretty dubious, and it was also associated with some cardiac conduction abnormalities, so like some QRS prolongation and risk for arrhythmias. So because of that, it just got taken off the market several years ago, and so certainly should not be used in the elderly, especially those with poor renal function. So looking at your general guidelines for selections of opioids, agent selection should be based on a few different things, so including things like pain intensity, other pharmacologic factors, if they have a component of neuropathic pain maybe, or if they're on other certain medications. Certainly looking at things like coexisting conditions, especially if they have like cardiac conduction issues or renal issues, and also looking at economic factors. So can the patient even afford the medication? For a lot of the older immediate release preparations, that's certainly not a big issue in a lot of cases, but with a lot of the newer agents coming out with more extended release preparations, certainly those can become fairly expensive. Looking at chronic or treatment of persistent pain, you definitely want to have a long-acting medication in conjunction with a short-acting opioid therapy. This allows you to have a nice baseline level of pain control throughout the day with the long-acting medication, and then the short-acting medications utilized for breakthrough pain. As far as route of administration goes, oral is going to be preferred for the most part, especially for outpatient management. Certainly, if they're in the hospital setting, IV is certainly a possibility. Rarely we see some transdermal use. Usually, this will be fentanyl, most frequently for those chronic pain patients. And again, dosing really needs to be individualized, so you want to make sure you're starting low and go slow and then titrate as needed. Nothing worse than going up too high on this and either making your patient really sick with the adverse effects or getting excess sedation from utilizing this. And make sure that the instructions are really clear for the patient to know that the long-acting medication is not as needed. You don't take it every few hours. This is only once a day or twice daily, because there can be issues where they may get confused on how to take it based on your instructions, and can lead to some pretty significant adverse effects. So the topic of conversions could probably fill up an entire lecture in and of itself, but essentially every opioid medication is going to have a relative equal potency between different agents, and so when switching medications from one to another, you really have to look at the conversions, and you'll find different tables are available in different places, and so eventually you'll find one that works for your setting. And so I'm not going to get super into detail on converting different opioids between each other, but certainly situations where you may need to think about a conversion would be if there was, say, a lack of efficacy with one agent. So if a patient had poor effect with morphine, you may just want to switch over to something like hydrocodone or oxycodone. Similarly, if the patient cannot tolerate the drug due to adverse effects, you may want to switch over. Certainly if you have issues where patients have become NPO for surgery, or if they're experiencing acute pain crisis, you may need to switch over to things like IV therapy, and vice versa, switching back over to oral therapy, and then looking at things like formulary, wherever you're working at, or reimbursement changes may make one agent more financially make sense for the patient versus another. So the thing you have to remember with these conversions is that it requires calculation of the total daily intake and the use of equal analgesic dosing tables. So essentially, you'd be looking at a patient who is on, say, oxycodone controlled release twice a day with, PRN breakthrough pain, every 4 hours with oxycodone. You want to calculate the entire total daily dose they get on average, including both the controller medication and then the breakthrough as well, when calculating your total daily doses. And so, again, use good caution when calculating the doses. There's no worse feeling than thinking you screwed that up and maybe gave the patient either, tenfold overdose or tenfold underdose, depending on what the situation may be. And in general, when you are switching over, once you have that actual calculation for what you're going to convert them over to, you generally want to start at 50 to 75% of that dosage, due to this phenomenon of incomplete cross-tolerance that occurs, to where even though you may be taking, say, 100 milligrams of morphine a day and can tolerate that very well, if I switch you over to an equal potent dose of fentanyl, you may not have all the tolerance there, and so you may get some kind of more dramatic therapeutic effects more than the patient's really bargained for. So because of that, you have this incomplete cross-tolerance to take into account and drop the dose some. Another big thing you'll see, especially on the inpatient side, is patient-controlled analgesia, or PCAs. So these are really nice, especially like in the post-operative setting. I see this a lot for some of our severe sickle cell patients who are coming in for pain crisis, sometimes for end-of-life patients, end-stage cancer and things like that. And basically the idea is you have a pump that is going to be providing a continuously hourly infusion. So you're going to have this basal rate that's going to be infusing continuously. And then you have additional medication that's available via a handheld button that the patient is going to be holding on to. And so the provider is going to be selecting not only the basal rate, but they'll also be selecting what that dose is when they click on the button, how often they can get that, so this lockout interval. So say for instance, every 6 minutes or every 10 minutes. And so an example would be, say, a morphine PCA, where you're administering 1 milligram per hour as a basal rate. So the patient's getting that regardless. And then every 15 minutes, they can hit the button to get a on-demand dose of 0.5 milligrams. And again, you titrate that based on a number of things, looking at, sedation scales. So perhaps you're providing too much and you need to back off some. Or you can even, with these pumps, you can look and actually prod the data to find out how many times they're actually clicking on that button. And so we've had some patients who will, unfortunately dealing with kids, they don't necessarily know any better, and so they'll sit there and just hammer on the button all day long. So it looks like they're trying to get 200 doses an hour when really they're just playing with the button. But certainly you could take this kind of information into account and looking at man, that patient was hitting the button every 5 minutes. Perhaps we're not giving enough of a basal rate, and so you can actually bump up the dose and see how those changes are reflected in how often the patient's hitting the button. So just some ways you can get to a better, titrate to a better effect for your patient, make sure their pain's really well controlled. So here's an example of a PCA pump where you'd have the medication in a syringe pump here. You can see on the screen where you could we could program your different parameters, and then the patient button where they would hold on to that. Oftentimes, because you worry about things like pain med seekers and things like that, there oftentimes be lockout codes so that the patient couldn't go in and actually change the dose themselves. There also would be keys for these as well that would do the same function. For some other pearls to go along with this, for persistent pain, really you're going to see that the basal rate plus an on-demand dose is going to be most effective. In some cases, though, the patient's only having, really kind of mild or more intermittent pain, giving just an on-demand dose may be appropriate. So instead of having a basal rate, you can set that at 0 and just let the patient kind of get an on-demand dose as needed. In general, you'll find that on-demand doses should be approximately 1/4 to 1/3 of the basal rate in most cases. But you'll see that kind of titrate and change based on patient situations. And so, like we mentioned before, that adjustments on this basal rate and on-demand dose really need to be based on actual PCA usage, based on how many times the patient's clicking the button and all that. One thing also to note that is really important, especially if you're ever writing like a post-op PCA order, that you should not be including other forms of opioid medication on top of this. So say for instance you have a patient who's on a PCA who's getting a basal rate plus an on-demand dose. You don't want to have like an outside PRN dose of morphine to give to the patient that is based on the nursing assessment, because then you run the risk of the patient's clicking the button to get the doses because that's what they've been instructed to do, and then the nurse is assessing the patient saying, oh well, maybe they need a little more, and it can lead to issues of over sedating the patient, needing reversal agents and things. So really we want to avoid having that situation. The other thing when looking at PCAs is you also want to make sure your patient's actually competent to use it. So if the patient can't actually control it, it's not going to be all that useful. So if you have a very small child, or if you have an older patient who doesn't have the mental faculties to operate the PCA, you might be better off to either use just a continuous infusion of the drug, or potentially have just PRN doses that the nursing can administer as needed. So moving on to adverse effects of opioids, they are certainly numerous. The frequent ones you're going to be seeing most often are going to be constipation. That's almost universal for opioids. And depending on how the patient tolerates the drug, you'll see some degree of nausea, vomiting, and of course sedation will be a big thing as well. With certain agents, you'll see that there's more or less histamine release associated with it. So for instance, morphine is very well known for causing a decent amount of histamine release, which will lead to rash and itching. That is a frequent reason to switch off of that over to something else for your patients. Less frequently, you can see that delirium can occur in certain patients. There's obviously the risk of respiratory depression, which is relatively low as long as you're using therapeutic doses. However, if the patient takes too many doses or ramps up the dose too quickly, as they build up to steady state, respiratory depression is certainly possible. And also consider the risk of abuse and diversion whenever you're prescribing opioids, due to the fact that patients may not always be completely honest with you and maybe just exhibiting drug-seeking behavior. So definitely something to consider depending on the situation. Some of the things we can do to help minimize some of the adverse effects include kind of titrating the dose up gradually. So again, that start slow and go low, or start low and go slow kind of mentality. You want to determine the cause of symptoms. So perhaps maybe it's not just opioid causing the problem. Maybe there's some other medications that are being causative as well. So say, for instance, they're on an opioid, they're having constipation, but they're also on anticholinergic. Perhaps there's some synergy there you should consider. You want to look at changing the dosing route or regimen depending on how the patient is tolerating it. So perhaps, if they have issues remembering to take their controller doses due to waning mental faculties, switching over to say like a transdermal route, something like that. Obviously, we'll talk about how to treat the adverse effects as we go on. Another option would be to switch over to a different opioid if none of these, if the adverse effects are not tolerable by the patient. And then you'll actually see that with a lot of the side effects, that tolerance will develop over time, usually within a few days to a week or so. That is true except for constipation, which is never really going to go away as long as they're on an opioid. And so we'll talk a little bit more about the treatment, but basically it requires this mush and push type of strategy where you're providing not only stool softeners, but also stimulant laxatives in order to help kind of stimulate the GI tract into increasing peristalsis. So again, constipation is a common effect due to opioids slowing peristalsis in the GI tract. And usual treatments don't really relieve opioid-induced constipation like we would see in other cases. So fiber and fluid really just not going to do it. Really, opioids are very, very potent. It's basically stopping everything up. So the bowel regimen in general should be started prophylactically whenever opioids are started. Basically, to prevent the constipation from ever starting up, you want to treat beforehand. So a lot of times we'll use something like a combination of Senna plus Docusate. So it'd be a stimulant with your Senna, and then Docusate, which is a stool softener. So there are products out there like that, like Senecot S, that have both of those products. Obviously, you want to monitor closely and adjust the medications as needed. So if they start to have diarrhea, obviously you might have gone too far. And then consider adding on additional laxatives if you need to with a different mechanism. So you can include something like an osmotic laxative, which helps to draw water into the GI tract to increase peristalsis. And that would include things like Miralax or polyethylene glycol that would kind of fit into that category. Now, looking at adjuvant and other medications used to treat chronic pain, we'll see that many chronic pain conditions are going to respond well to adjuvant medications because, oftentimes it's not just maybe a somatic pain, but there may be a neuropathic pain in conjunction with that. Or, the neuropathic pains in general will respond pretty well to adjuvant medication. So this is where we'll run into things like anticonvulsants. We'll see lidocaine transdermal or lidoderm topical preparations. And we'll also see where tricyclic antidepressants fall in this as well. Again, responses can be variable to different agents among and within the classes. So just because a patient doesn't respond well to one anticonvulsant does not preclude you switching over and trying another or moving over to something like a TCA. So some of the ones we'll talk about include our antiepileptics, antidepressants. We'll talk about skeletal muscle relaxants, but there's even other things you can consider utilizing things like corticosteroids, especially if it's an inflammatory condition, botulinum toxins. So this would be like your Botox. I definitely see that a lot used for some of our rehabilitative patients. Rehabilitative medicine patients, kids who have a really significant spasticity in their muscles. You can utilize Botox in order to help kind of paralyze the muscles and deal with some of that. So lots of different adjuvant medications rather than just relying solely on opioids. So looking at our antiepileptics first, so we've seen that they've demonstrated effectiveness in a variety of neuropathic pain states. So some of the more common ones you'll see being utilized include things like carbamazepine, gabapentin, lamotrigine, and pregabalin. Certainly see a lot of gabapentin and pregabalin being utilized for things like fibromyalgia and other kind of neuropathies. Again, these agents, a lot of them are going to be causing a lot of sedation, mental clouding, dizziness. So because of that, you also want to start low here and go slow as you titrate up and to determine response. And again, these may not be as immediate onset as you would see with our opioids. So again, several week trials oftentimes are needed in order to assess full efficacy. We then have our tricyclic antidepressants. Again, you guys know these drugs pretty well. They're going to be blocking the reuptake of norepinephrine, which helps to modulate pain responses in some of those nociceptive nerves. really this has been considered a gold standard in neuropathic pain for a long period of time because it's an older drug and it's been used quite frequently. It's really kind of limited in its use though nowadays due to side effects. So especially the anticholinergic effects, we have things like constipation, urinary retention. All those things can definitely be worse, intolerable by the patient. But certainly if you have cardiac abnormalities, these conduction issues can be a problem. Sexual dysfunction, weight gain, those things can potentially intolerable enough that the patient just wants to switch off completely. And so this is why a lot of the antiepileptics have kind of taken center stage for this in the past, or as we move forward. But certainly these will be utilized as kind of backup if some of the anticonvulsants aren't really working. Local anesthetics are also going to be utilized pretty frequently to use to treat neuropathic pain. These are going to be working specifically by blocking neuronal sodium channel conduction. So by blocking the sodium channels, you prevent propagation of action potentials down the nerve. So if you prevent the nerve from firing, you're preventing the pain signal from reaching the brain. So a couple of different topical agents available. This would include things like Imla, which contains lidocaine and prilocaine, and also topical lidocaine patches, so lidoderm patches. You'll see these being utilized a lot for things like postherpetic neuralgias and things like that. Another interesting thing that we see being utilized, especially in the post-op setting, we see this quite frequently in our orthopedic cases, are going to be either epidurals or local and regional nerve blocks utilizing ropivacaine or bupivacaine. These are fairly long-acting anesthetics which can be utilized to kind of pinpoint the pain. So rather than using a systemic opioid, you can try to target and be a little bit more focused on where you're applying the pain relief or the numbing here in this case. So that way you kind of have pretty significant reductions in your opioid use in the postoperative setting. So whether it be an epidural or you get actual local regional blocks, especially in the some of our orthopedic cases, we have a lot of things like limb lengthenings or scoliosis cases and things like that where these can be effective. Especially if a patient is having pain issues related to muscle spasticity, muscle relaxants can be very useful here. So this includes things like baclofen, cyclobenzaprine, metaxalone, methocarbamol, tizanidine. These are very beneficial in cases of muscle spasm because they're going to be working specifically on the GABA B receptor. We've talked about benzodiazepines before working on GABA A receptors, but these ones work on GABA B. And what we see is that they help to interrupt this kind of pain cycle that occurs where the pain causes the spasm, which causes more pain, which causes the spasm further. Kind of helps to relieve some of that stress caused by the spasm to deal with, you have less pain overall. So this is helpful to improve things like range of motion, helps them regain some of their function. It really helps to facilitate a lot of this rehab and therapeutic exercise. Because they are working with GABA channels, again, drowsiness, dizziness, all these things are going to be very, very common with these drugs, especially if you need kind of higher doses like we see for some of these more severe spasticity cases. Capsaicin cream can also be utilized for local pain management. Again, this is a drug that's going to be working by activating pain fibers, so it really is a drug that has really poor compliance due to the fact that it's a topical cream. It's not super. It's not as convenient as taking a pill for pain, and then it really is, if anything, might be kind of painful at first. It's going to burn, just like putting hot sauce on something might burn. So by activating these pain fibers, it's going to be releasing substance P. And then eventually, once these fibers kind of run out of substance P, once they're kind of desensitized, basically it's not going to be able to fire any further, and so you get less pain signal transduction happening from the site locally. So again, if it's stuck to and being utilized consistently, you see a significant reduction in pain for localized conditions. So again, minor aches and pains in the muscles or joints, and these neuropathic conditions such as like postherpetic neuralgia. So again, the biggest side effect you're going to see here is going to be this temporary burning or stinging following use. And again, this is going to go away over time as these pain fibers get desensitized. One thing you should always counsel your patients on is make sure they wash their hands really, really well. I'm sure all of you have been cutting up jalapenos before and accidentally rubbed your eye. Well, the same thing happens here. So it can be very, very, very painful if it gets into contact with mucous membranes. So really recommend washing off their hands very thoroughly before touching anything else. Tramadol, I'll mention here again. We've talked about it as an opioid. Again, this was recently made a C4. Now, this is kind of a weak mu agonist, so even though it's classified as an opioid, it really doesn't get a whole lot of, doesn't really get that full agonism at the receptor as you would see with something like a morphine. So it's utilized more for moderate or moderately severe pain, and usually utilized as an adjuvant medication. The other kind of benefit here for treatment of neuropathic pain is it has weak inhibition of the reuptake of norepinephrine and serotonin. So by similar effects that we see with the TCA, you get some of this similarly with Tramadol. Typically, it's going to be better tolerated than opioids, and some people believe that it is because it's only a partial agonist at the mu receptor. There's less abuse potential. But because for a while it was a non-controlled substance, and especially mid-level practitioners could prescribe it kind of with impunity, it was seen as an alternative by the drug seekers, and thus it kind of became had a higher abuse potential than the drug its mechanism of action would really lead you to think. So that's partly why it got reclassified as a C4 medication. Again, adverse effects are going to be very similar to other opioids, so dizziness, nausea, constipation. And usually if you need to reverse an opioid, you utilize the reversal agent naloxone or Narcan. What's interesting here is because this is a really synthetic agent, it doesn't really get fully reversed with naloxone, so sometimes you need to have higher doses than normal in order to help reverse the effects here. So in conclusion, for the pain management section, pain management is very complex. Complex disease state or complex topic. I could spend an entire semester talking about it. And treatment really needs to be individualized to focus on very specific patient parameters, patient goals, and all the other facets that go along with that. And providers, you can help to play an important role by educating patients appropriately, guiding the selection, titration of drug doses, and also conversion from one agent to another. As you go along, you definitely want to be assessing for effectiveness, measuring pain scales and sedation scales, and looking for adverse effects. And if they are experiencing adverse effects, help them to manage that, whether it be treatment for constipation or switching over to other agents entirely, or adding on new adjuvant medications. Moving on, we'll talk about venous thromboembolism. Some of these medications we've talked about previously, but certainly they may be worth revisiting here as a refresher. Now, VTEs are potentially a fatal disorder, and certainly after major surgery, especially in orthopedic surgery of the lower extremities, patients are going to be at risk, especially if they're laid up in the hospital for a prolonged period of time, they're immobile, or if they happen to have a hypercoagulable state to go along with that. Again, typically it's manifested either as a deep venous thrombosis, which again is rarely fatal, but certainly if that can dislodge and become a pulmonary embolism, that can be very, very dangerous, potentially fatal immediately. If they get really a massive PE developing. So some risk factors you should consider when evaluating a patient at risk for VTE is going to be obviously age is going to be a big factor. So the older the patient is, generally more prone to embolism than they are. Obviously, history of previous VTEs, whether it be related to their hypercoagulable condition or whatever happens it may be. And then also looking at issues of venous stasis. So certainly if the patient is obese, which maybe have led to their orthopedic operation, paralysis, certainly if they're not moving around in an immobile state, that's going to make them more at risk for having venous pooling and thus propagation of a clot. When you're having vascular injury as well, so with the hip or knee replacement certainly is possible. Issues of hypercoagulable states, so if they have a factor deficiency or pregnancy can be a problem here. And then one of the big things I see leading to VTEs would be estrogen-containing therapy. So I see a lot of, especially some of the young nurses that I work with who are on estrogen-containing birth control, certainly are at risk for developing a VTE related to that. And we'll talk more about that when we get to our OB-GYN section next. So just a quick picture looking at thrombus formation. So again, imagine this is a vein in a leg that's been immobile, secondary to like a major surgery. Certainly if you have pooling of the blood in the venous system, you can have a platelet thrombus that can develop, and eventually you can see this propagation happen where you get this fibrin clot that can develop. Obviously that can break off and eventually form clot or embolus elsewhere. So the signs and symptoms, again, DVT may really be asymptomatic, but certainly things you may see include things like leg swelling, pain, warmth, this kind of palpable cord where the clot is. And then with PE, again, these can also potentially be asymptomatic, but they can be also very nonspecific. So things like cough or chest pain, palpitations certainly, and then you can look at things like hemoptysis. And in general, it's always that question of like, okay, is this a PE or is it an MI? So you have to do the appropriate testing to determine which is which. So obviously the way to treat a clot is going to be using anticoagulants. So here I present the coagulation cascade just to give you a reminder of the kind of the several factors are going to be involved in here, the different clotting factors. Obviously you have your intrinsic system that's going to be more activated by internal factors, where you have extrinsic system being activated by things like tissue factors. So this is where you see tissue injury coming into play. So certainly after major surgery, orthopedic surgeries, you can see kind of both systems being involved here. So because of that, that's why you oftentimes see a lot of these patients are going to be on prophylaxis for clots post major surgery in order to help prevent these clots from developing in the first place. The kind of the gold standard for either treatment or prevention of postoperative embolus is going to be heparin. As you remember, this is a very large kind of sugar-ish type molecule that's naturally occurring within the body. You can see here there are many monosaccharide units long, and essentially it's a very large molecule. So you can see here anywhere from 3,000 to 30,000 kilodaltons. And they can kind of range in size depending on the molecule you're looking at. Now, unfractionated heparin itself, the mechanism is that it's working to increase the activity of antithrombin 3. Now, antithrombin 3 normally is going to be inactivating factors 2, 10, 9, 11, and 12. Now, heparin is just going to come along, and I'll show you a picture in a second, that's going to help antithrombin 3 work that much faster. So it kind of helps provide this kind of scaffolding or platform for the binding of both thrombin and antithrombin. Again, this increases the inhibitory factor of antithrombin 3 by about 1,000-fold. You'll see that different subunit combinations are going to be more specific for different factors, and this is important when we talk about our fractionated heparins. Once the factors are inactivated, antithrombin 3 can then be unbound and go along and do its thing again. So here, looking at the picture, I'll try to bring up the laser pointer. Here you normally have an unfractionated heparin. Notice it's a pretty long molecule. Here it's going to incorporate along with antithrombin, and when that does so, it's going to either bind to things like factor 10A, factor 2A, any of the factors we mentioned before, and helps this kind of just facilitates this process a little bit more easily in order to help inactivate the factor and lead to the anticoagulant effect. Heparin is normally extracted from porcine intestinal mucosa or bovine lungs, so several sources for it to be available. Has to be either given IV or sub-Q due to the fact that it's not well absorbed otherwise, especially from the GI tract. And then typically you'll have immediate onset with IV administration or within a couple hours if you're giving it subcutaneously. So certainly if you are giving it as treatment doses, you'll generally always going to be giving it IV, whereas with prophylaxis you can get away with using sub-Q dosing. This is also beneficial because it is so large that it has a hard time crossing the placenta or the blood-brain barrier. And so because of that, it does not, it's kind of the drug of choice for pregnant patients. Now the drug is somewhat metabolized in the liver and then renally excreted, so you certainly may see increase in half-life for those patients who have significant renal or liver dysfunction. Looking at the monitoring parameters, generally you're going to be looking at your APTT, and basically what this is looking at is a ratio, looking at the patient's APTT versus a normal control, and then based on that you kind of get this therapeutic ratio that you can look at. Some people will have their parameters, their guidelines set up in seconds. Some people will look at the ratio. So it just all depends on what the protocols are at the location you're working at. Certainly our indications for heparin are going to include either treatment or prevention of venous thrombosis, pulmonary embolism, MI, and also during coronary angioplasty. Biggest toxicity with any of these anticoagulants is going to be bleeding, obviously. Relatively small percentage of patients will have a major bleed, in which case we would utilize a drug called protamine, which will have to bind up the heparin and inactivate it. The other big thing we want to watch for, especially with more prolonged use of heparin, is going to be this heparin-induced thrombocytopenia, or HIT, estimated to be around 0.5% incidence, and really is going to be occurring with more long-term therapy. So generally happens after 5 to 10 days of therapy. And essentially what's happening is that your body is developing antibodies to heparin plus this platelet factor 4. And when that happens, these antibodies are formed, they're going to be activating platelets. So again, even though they're causing a thrombocytopenia, it's because they're activating the platelets, and so you get these kind of microclots that can develop throughout the body. Obviously, you want to discontinue heparin immediately, and in which case you'd use something like a direct thrombin inhibitor like Argatroban or Meperidine in order to combat that. Obviously, you want to avoid things like low molecular weight heparins and warfarins until the thrombosis actually resolves, but usually patients end up being bridged over to warfarin in these cases. Moving on, then we have our low molecular weight heparins. So these are essentially heparin molecules that have been cleaved up, and so are generally much shorter. Generally going to be around 15 monosaccharide units in length. This can either be done chemically or enzymatically. And so the preparations that we'll see being utilized is most frequently enoxaparin, but certainly depending on the formularies of where you go to, either dalteparin or tenzaparin may be utilized. So looking at the effects that low molecular weight heparins have on different clotting factors, you'll see that it has pretty minimal effects on thrombin, or 2A, which heparin did have good activity against. Mainly this is because it's not really long enough in order to help facilitate the binding between that and antithrombin 3, but certainly it will have good activity against factor 10A. So looking at something like the ratios of activity of 10A to 2A with unfractionated heparin, it's around 1 to 1. Whereas with low molecular weight heparins, you'll see around 2 to 4 times the 10A activity compared to the 2A activity. Looking at the picture here, we have our low molecular weight heparins. This is shorter than the original unfractionated heparin was, and while it can help to bind up factor 10A quite well, again, it's simply not really made to bind up factor 2A, so it's a harder time in activating it. So still will work a little bit, but really 10A is where we're going to be getting a lot of our activity from. Looking at the low molecular weight heparins, similar to unfractionated heparins, they're not going to be able to be absorbed orally, so they are generally going to be given sub-Q, either as a fixed dose or a weight-adjusted dose, once or twice daily. Most of the time you're going to see these being utilized, say, twice daily, unless they have like renal dysfunction. So renal dysfunction is going to be a huge thing to consider when looking at your dosing. Especially for adults, you'll see that they'll end up getting, for prophylaxis, you'll see a fixed dose where they'll say maybe get 30 milligrams twice a day or 40 milligrams once a day. Whereas for treatment doses, that's where you get more into weight adjusted, so you might get 1 milligram per kilogram twice a day. The reason for that twice a day dosing is because it's a relatively short half-life, and because it doesn't really affect factor 2A all that much, you really don't see any effect on the APTT. What we are going to see is anti-factor 10A assays that are going to be able to be measured, so you can actually measure the activity of the anti-10A level and measure the activity of the low molecular weight heparin to help guide your dosing. Now, typically for adults, you don't really need to worry about the anti-10A level because the published dosing is good enough to get you to therapeutic level. Certainly if you have extremes of weight, so if you have a very small patient or a very, very large patient, this might be useful to make sure you're either giving not too much or not too little in order to hit that right therapeutic window. And certainly in renal failure, dialysis, those are all the indications where you'd want to utilize anti-10A levels. Usually in a lot of these cases, though, especially like renal failure, they would just switch the patient over to unfractionated heparin in a lot of cases. Toxicity-wise, you generally see less bleeding than you do with heparin, but it may also cause HIT. So this would be a contraindication to getting this if you have a previous history of HIT with heparin. You also have fondaparinux or Rixtra, and this is a even smaller molecule that is going to be working exclusively on factor 10A. Again, is not going to require much monitoring unless you are concerned about those large patients or the significant renal dysfunction. You can get anti-10A level in that case. So it's a little bit longer half-life, around 17 to 21 hours, so you're only going to be giving it once daily. And again, typically not as much data to support use in severe renal failure, so you wouldn't use it in those patients. So there's no like dialysis dosing for Rixtra. This one has very low incidence of HIT, and so some people believe that if you have a history of HIT with heparin, you may be administered this medication without fear of causing that to come back. Certainly this one can get use in either knee or hip replacements, pulmonary embolism, venous thrombosis. All of these really have very similar indications when it comes to these kind of orthopedic situations. The next drug we'll talk about is going to be warfarin, which, again, if you need to amaze your friends with your knowledge of pharmacy trivia, you'll remember that this is an acronym for the Wisconsin Alumni Research Foundation. Warfarins have been utilized as rodenticides for a long period of time, but now we see they're being utilized as good, more long-term preventative medications for either treatment of clots that have already occurred or prophylaxis to prevent clots from developing. And the mechanism of this drug is very different from the heparins. Here it's going to be working as a vitamin K antagonist, so the factors it's going to be working against is going to be a little different. So it'll still work against factor 2, but you'll see 7, 9, 10 being affected as well. And then you'll also have protein C and S being inhibited here, mainly because these need to be metabolized within the liver, and they utilize this reduced vitamin K in this cyclical process here. Warfarin will come along and inhibit that epoxide reductase enzyme, and by doing that, it prevents the production of new clotting factors since vitamin K is not really able to be utilized appropriately. So, by inhibiting that enzyme, you have less clotting factors and less likely to either start or propagate a clot. Again, just another picture to kind of show the same thing where warfarin's going to be coming in and working to inhibit this enzyme. If you notice here as well, this is an important point at the bottom where you can see that warfarin is a racemic mixture, but certainly the S-warfarin is going to have a lot better activity at inhibiting this enzyme versus the R-warfarin. But also notice that the different enzymes will be metabolizing these drugs. So CYP2C9 is an important drug interacting enzyme for S-warfarin versus things like 3A4 is going to be important for the R-warfarin. So at therapeutic levels, you're going to see a decrease in the vitamin K dependent synthesis of these cofactors by around 30 to 50%. And the activity of those that are still synthesized is maybe only about 10 to 40% of what it normally is. The thing to remember here is that it has a delay in onset due to the fact that it doesn't affect existing factors that are already circulating in the bloodstream. Once these are depleted, though, and you have warfarin on board inhibiting vitamin K, you'll see that that's when the anticoagulant factors start to come into play. Looking at the half-life of the different clotting factors, you can see why this it takes roughly 2 to 3 days to really see the full effect, really before you start to see the effects of warfarin kick in. interestingly enough, they actually have an initial hypercoagulable state since protein C is actually an anticoagulant in nature. So initially, you will have patients maybe at increased risk for clot. So this is why you'll have patients who will bridge therapy with heparin until they can get to a therapeutic INR. Warfarin is convenient to use for outpatient therapy since it's given orally. It's absorbed very well. It has a pretty long half-life, so it takes a little bit to get into steady state here. Again, looking at the drug, the enzymes that are going to be metabolizing it, you'll see that interactions with 2C9 are going to be very, very important here, either inhibitors or inducers, and also 3 or 4 will be important as well. This drug, though, is not to be used in pregnant women due to the birth defects that it can cause. So really, most time patients who are pregnant who need to be on longer-term therapy usually end up getting put on sub-Q heparin during the duration of pregnancy. Again, looking at drug interactions that can occur with warfarin, so things that will decrease the actions of warfarin. You can have things that influence the uptake and metabolism of oral drugs or vitamin K. So, for instance, green leafy vegetables, very high in vitamin K. So, if you have a high vitamin K diet and the dose of warfarin has not been adjusted to take that into account, that vitamin K is still going to be active in order to help develop those clotting factors. So this is one of the biggest things when educating patients is that they need to be on a consistent diet. If they want to eat 7 bowls of spinach a day, that's fine. But they need to keep their dose consistent, because if you adjust their dose to them eating 7 bowls of salad a day, and all of a sudden they stop eating spinach at all, then you're going to see their INR is actually going to climb up pretty high because they have that limited vitamin K intake. And then anything that's going to be affecting the synthesis or function or clearance of the clotting factors, to increase this function of the clotting factors is going to be decreasing the actions of your warfarin. Things that can increase the activity of warfarin to make it more effective as an anticoagulant, you would see things like CYP2C9 inhibition, since it will not be as effective at metabolizing that S-warfarin. Things that affect protein binding, so because it is highly protein bound, if you had another drug come and kick warfarin off of the proteins, that could lead to an increased therapeutic effect. Anything decreasing the amount of vitamin K that's being absorbed. So say, for instance, antibiotics are a big thing that you have to consider as an interacting agent here. So essentially, vitamin K is metabolized partially by gut bacteria, and that's what allows it to be absorbed into the GI tract. So if I were to give an antibiotic like amoxicillin or Bactrim that disrupts this flora, you won't be able to process the vitamin K as well unless you will have an increased effect of your warfarin, because again, you're not making as many clotting factors. And certainly, liver function is going to be important here, because the liver, if it's not functioning appropriately, it's not going to be making clotting factors appropriately, unless you'll have increased activity of warfarin here. And just in general, elderly tend to have a little bit more increased effect from warfarin, just due to less physiologic reserve than you would see in, say, a younger patient. As far as monitoring parameters go, we noticed that with heparin, you could measure APTT. With low molecular weight heparins, you saw the anti-10A level is going to be utilized here. But for warfarin, we're going to be looking at the PT and the INR. INR is kind of the international normalized ratio that helps to allow kind of comparisons of measurements of PT between different labs and different reagents and things like that. So in general, you're going to be looking at your INR to get to a range of anywhere between 2 to 3 for most cases. So especially like for AFib and VTE and things like that, an INR 2 to 3 is appropriate. For certain conditions, like if you have like a mechanical heart valve replacement, higher ranges will be shot for, so like 2.5 to 3.5 in those cases. So another thing to consider, we mentioned the higher levels of INR being utilized for mechanical heart valves, but also some patients may be a little bit more warfarin resistant due to just pharmacogenetic differences in the metabolism of the drug. And then certain patients might be actually more sensitive to warfarin, so their INR will rise kind of inappropriately even at lower doses. And oftentimes this is due to kind of less efficient metabolism if they have kind of poorly metabolizing CYP2C9 alleles. And so you can see anywhere between 10 to 20% of Caucasians will have a decreased activity in CYP2C9, and you can have different variations on this. So you can have some that are maybe only have a certain small percentage reduction in activity. Some may have very significant reduction in activity. So it's going to be important when starting out your patients on warfarin. If you see more exaggerated effect, could be related to this activity here. Obviously, bleeding is going to be one of the big toxicities you're looking for. Generally, you're going to have pretty low bleeding rates with an INR in the normal ranges of anywhere between 2 to 3.5. But certainly, as INRs climb, you're going to see increased risk for things like cranial hemorrhage. And then once we get above 5, we start to consider things like giving vitamin K. By giving vitamin K, you basically can allow the liver to start producing some of those new clotting factors. And then anytime you're having a serious bleed, this is where we're going to give vitamin K in addition to fresh frozen plasma, because again, that already has active clotting factors in it that can be utilized immediately. Vitamin K is going to take some time to have effect, whereas FFP is going to be immediate. Obviously, we're about birth defects if given to a pregnant patient, and then also you can see issues of skin necrosis if you have patients who have a protein C or S deficiency. Because warfarin can be such a finicky drug and requires so much education and buy-in from the patient, it's highly diet dependent, requires a lot of monitoring until you get up into the right range. So many drug interactions. It's very difficult for some patients to really stick to this and be successful with warfarin. Other benefit, though, is easily reversible with vitamin K or FFP. We have some newer alternatives on the market now, so things like Pradaxa or Dabigatran and rivaroxaban are available now, and these are going to be good alternatives for patients who may have better physiologic reserve and would not be very unlikely to need to be reversed because there's some issues with these drugs, as we'll see. Dabigatran is an oral direct thrombin inhibitor, so again, it's going to be preventing that conversion of fibrinogen over to fibrin, and also activation of the factors 5, 8, 11, and 13. Its marketed uses for either DVT, PE, or AFib. And again, it's not going to have any actual routine monitoring, so you just basically start at a dose, and then you don't have to worry about checking INR or things like that. Big issue we see here is the bleeding, is the fact there's no available antidote. So there's some things coming down the market as we go along. We'll see there's actually some monoclonal antibodies that are starting to be developed that can neutralize these drugs. Go figure, they're being made by the same company that actually makes the parent drug, but you can go figure. And the other thing to look at with dabigatran is this dialyzable. If you did have a patient who's having an active bleed, potentially you could pull some of the drug off with this, but certainly you need to adjust the dose based on the renal function of your patient. And then rivaroxaban, this one's going to be an oral factor 10A inhibitor, so it's kind of like either fondaparinux or enoxaparin in order to inhibit factor 10A. Again, utilized for DVT, AFib, PE, and no routine monitoring here. Bleeding can be reversed with prothrombin complex concentrates, but again, this is a partial reversal, so it's not nearly as good as you would see with like a reversal of warfarin with FFP. And again, this one is somewhat renally excreted, but there's no good guidance for dose adjustment for these patients. So looking at patients getting orthopedic surgery, typically for things like total hip arthroplasties, total knee, hip fracture surgery, oftentimes they're going to be recommended to get 10 to 14 days of anticoagulation. You can utilize pretty much anything, so you can utilize low molecular weight heparins, fondaparinux, things like apixaban, which we've mentioned previously, dabigatran, warfarin. In some rare cases, you want to use aspirin, but again, you're not really going to get as much bang for your buck out of aspirin as with a lot of these other anticoagulants, but it just depends on your patient, depends on allergies, depends on what they can afford, things like that. In general, you'll see that the low molecular weight heparins are generally going to be preferred, and then depending on if your patient has a hypercoagulable state or history of clot, you may need to extend treatment out in the outpatient setting. So looking at this sheet here, we kind of see our algorithm for what we're going to do if we are suspecting that we already have a VTE that has developed. So certainly once we have once we have a confirmed VTE, so whether by Doppler or whatever confirmation we have, once we have a venous thromboembolism, the question becomes, okay, well, can we anticoagulate this patient? There are some patients you really can't anticoagulate due to numerous conditions, in which case you may need to consider putting like a vena cava filter in order to help prevent PEs from developing. Once we go down into the question of whether or not they actually have a pulmonary embolism, if yes, then you need to start doing some risk stratification. Typically, if it's a massive PE or if they have any degree of shock, this is when you're going to consider using things like thrombolytic therapy. So I know we've mentioned we talked about MIs, we talked about alteplase or recombinant tissue plasminogen activator. That's going to be utilized in order to help kind of lyse that clot. Otherwise, you'll see if we do not have a PE diagnosed, we can kind of go to this other pathway and look at whether or not it's an extensive proximal DVT. If it is, again, you're going to consider looking at thrombolytic therapy. So again, this is just the bottom part of the previous slide here. So if they've either gotten thrombolytic therapy, or we say no, they don't really need thrombolytic therapy, they're not that sick, this is where we want to consider initiation of anticoagulation therapy. So here you'd either start with unfractionated heparin or low molecular weight heparins, and then you can consider adding on as well things like warfarin or rivaroxaban. And basically what you're going to do is bridge your patient over with the heparins until they're at a therapeutic level with the warfarin or the rivaroxaban. Let's say you're having a known clot. This is when you want to use longer-term therapy in order to prevent recurrence. So they would be treated for usually about 3 months or so. Once they've been treated for this period of time, you're sure they don't have any ongoing disease, then you look at what the possible causes were for the clot. So again, was it provoked by a reversible risk factor, things like estrogen-containing products? If that's the case and you've eliminated that risk factor, then you can stop the anticoagulation. Otherwise, you need to looking at long-term therapy and periodically kind of reassessing the risk-to-benefit ratio for your patient. So, again, looking at things like their fall risk. If it's an elderly patient who is really prone to fall and hit their head and have a intracranial bleed, that might be a little bit more risky and not quite so beneficial than just then their chances to have a clot again, basically. So again, it's very specific to assessing a patient. But in general, you'll see that initially they're going to be managed with this unfractionated heparin or low molecular weight heparin, and then bridged over to either warfarin or one of the oral either direct thrombin inhibitors or anti-10A inhibitors. So anywho, so that concludes it for the orthopedic section. Monday we will go over OB-GYN and then finish up anything else on the Thursday lecture, and then we'll do a quick review for the test on Monday. Again, if you have any questions, let me know, or we can talk about it on the Monday class. Thanks so much.